Ioannidis is an epidemiologist who specializes in analyzing data. He's a professor in disease prevention at Stanford University's School of Medicine. Google Scholar says he's among the 100 most cited scientists in the world. Dr. Ioannidis, I tried to synthesize a lot of data at the outset, some of which was yours. I know that you recently updated your data and shared that with a medical journal. Has anything changed, and what is it that you want the audience to most know about your research?
Thank you for the kind invitation, Michael, and for the opportunity to discuss that. As you know, the Santa Clara study on seroprevalence is one among many studies that have tried to assess how frequent the frequency of COVID-19 is in the general population. We received an enormous amount of very constructive comments from many colleagues, and both myself and our team are very grateful for that. We have updated the paper with far more data, far more negative controls, so as to minimize the uncertainty about the error of the test that we used, far more analysis trying to explore different biases that lots of colleagues were thinking that might affect the results, and also improved and enhanced methods to try to reduce and calculate the uncertainty around the estimates that we get. The results are still very robust. The conclusion is that based on what we see, this infection is very common. It's far more common compared to what we thought based on the documented cases. Most likely, most of these people had no symptoms. They did not even recognize it, or they had very mild symptoms. And this means that we have a huge iceberg below the tip of the iceberg that we had been documenting until now. I think this is probably good news. It means that for the average person being infected, the risk of having severe disease and the risk of dying is much lower than we thought. So it is a common and mild infection. At the same time, it can be a devastating infection. There's no doubt about this. But by now, we have learned where exactly it hits and where it can be devastating. It can be devastating when it hits nursing homes. It can be devastating when it hits hospitals, infects personnel, physicians, staff, and then we have hospitalized patients getting infected. We see that paradox in many people, for example, in children and in young adults. It is less severe than the common flu. In middle-aged people, it's about the same. In nursing homes and in hospitals that get infected massively, it can be a disaster. So we can use that knowledge to try to navigate into that spectrum, try the settings and the individuals who are at highest risk, at the same time probably have some optimism about the prospects of reopening our society before we get many adverse consequences by prolonged lockdown measures.
Dr. Ioannidis, earlier this week in the Washington Post, 4 individuals, 3 of them with Harvard affiliations, were critics of this analysis. And among other things, here's what they said. 2 recent studies from California using antibody tests designed to look for immune markers of previous infections seem to suggest that the virus is much less deadly than many previously thought. But beware of these findings. They have not been vetted and should be recognized as such. What would it take to vet your findings?
I think that any single study is a single study. That includes our own. Any single study needs to be seen in the context of other pieces of evidence and other investigations that are carried out. Have multiple studies, not just the Sahara or the LA County. We have data from Miami, we have data from New York, we have data from the Netherlands, from Italy, from Germany, from Switzerland. They all give the same message, more or less. Of course, there's differences across locations in the extent that susceptible populations have been heavily hit. New York is not going to be the same as Santa Clara. There's no doubt about that. We welcome all constructive criticism, and peer review should be done. This is exactly why we made that work available in open public view for everyone to comment, and we're grateful for all the comments that we received. I think that the work still holds true, and other studies suggest that this is still the same, but no study will be the final.
Sum up. What is it that folks most should know? And we're looking at our television screens, which are showing us 65,000 plus have died in the United States. Now you're here and you're saying, hey, it's much more widespread and therefore far less fatal. Okay, what should policymakers therefore do?
I think that this knowledge gives us some leeway to take some steps towards revisiting our current policy of lockdown. There's no way that we will just move away from lockdown immediately, and this will be an error. My suggestion would be to have a science-based, data-driven approach, try to balance what we know in terms of how common the infection is, get some accurate estimates of how active the epidemic wave is at a given moment, and this may vary from one place to another, and also balance our bed reserves and capacity, because we really want to have bed reserves in case we make a step towards reopening that is not correct. We do want to have reserves available. If we do that, I think that gradually start considering relieving some of the draconian measures and have very close eyes on what happens as we do that. I'm not sure that all the changes are going, but some will, and I think that there's plenty of room for optimism.